Hi, everyone. Again, thank you all for joining tonight. We are going to get started in about 2 more minutes. Thank you. Hello again. Good evening, and thank you all for joining in our last listening session, supported in a partnership with the Georgia Prevention and Care Council and also the Ryan White Atlanta Planning Council. It gives me great pleasure to see all these beautiful names across our Hollywood squares. My name is Daniel Driffin. I had the pleasure of serving as the first vice chair of the Ryan White Atlanta Planning Council, in addition to a member of the G-PACC's team, the G-PACC's Coalition. I'm going to have my amazing co-host, Tito Terry, introduce himself so we can jump in and get started. Tito, go ahead.
Well, good afternoon, everybody. Thank you for that wonderful introduction. Right back at you, sir. An amazing advocate and a great honor to work with. But I am Tito Terry. I'm the District 4 HIV Coordinator, but I'm also a G-PACC co-chair. So that's who I am. So welcome, everybody.
Thank you, friend. Again, we welcome you to our last listening session as we prepare to write the next 5 years of what HIV prevention and HIV care look like across the state. So if you give me 1 second, I will share our slide set tonight and we will get our conversation started. Let me tell you, it's a lot easier having multiple screens versus working off of a laptop. All right. And as I present, please, if you guys cannot see the slides, cannot hear me, just let me know. And I will rally on our other co-presenters to accept new folks as they come into the room. So again, thank you all. Tonight, we have the pleasure of talking about pre-exposure prophylaxis, or PrEP, across our key communities in the state. So just before we begin, we'll actually give 2 more sentences about the Georgia Prevention and Care Council, followed by a 2-sentence overview about the Metropolitan Atlanta HIV Service Planning Council. Tito, you want to take the G-PACC's side?
Sure. So just start off by saying that, as we all know, the purpose of HIV community planning is to create a seamless, continuous services for those at risk, for those infected with HIV. And basically, to sum it all up, in '93, the Centers for Disease Control mandated that any state receiving federal funding for HIV/AIDS must develop an HIV community planning group to develop a comprehensive HIV prevention plan. And the same goes for the Ryan White Care Act of 1990. So in 2014, the Georgia Department of Public Health sunset the previous prevention-only planning body and began the process of planning for integrated prevention and care activities, along with creating one comprehensive statewide integrated planning group. Georgia Statewide Integrated Planning Council. And yes, I'm aware this is more than 2 sentences. is known as the Georgia Prevention and Care Council, or as we like to call it, G-PACC. It was designed to foster an integrated planning process that encourages parity, inclusion, and representation among all community members. Members of the Georgia Prevention and Care Council reflect the epidemic in Georgia while simultaneously, that's my word of the day for everyone, if everyone's curious about that, because I've said it many times today, involving stakeholders who reflect the comprehensive need to address service delivery systems, unmet needs, and gaps in care and perceived barriers. So the mission of our G-PACC, as Mr. Daniel knows, is to collaborate with the state office with recommendations to improve the HIV continuum of care in the state of Georgia, strengthening the scientific basis, community relevance, key stakeholder involvement, population or risk-based focus of HIV prevention interventions and high-quality care in the state, communication and coordination of services across the continuum of HIV's prevention, care, and treatment. So that's just a little brief intro of what G-PACC does.
Thank you, friend. Greatly appreciate it. Very similar to G-PACCs, we have something a little closer to the local jurisdiction in the form of the Metropolitan Atlanta HIV Health Services Planning Council. It's a mouthful, okay? But if you've heard about the Part A Planning Council, that's who we're talking about. The Part A Planning Council takes care of close to 18,000 people living with HIV around 20, that spreads around 20 counties, specifically around the Metro Atlanta. We provide federal resources to organizations that provide medical and supportive services for people impacted by HIV. For more information, you can always visit us at www.ryanwhiteatl.org. We have meetings every other month, and we welcome you to come in, learn more, and join the fun. So let's go to this next slide. So a little bit more about the Georgia HIV Integrated Plan. So every 5 years, as Tito was saying, the CDC and the Centers for Disease Control and Prevention, and also the Health Resources and Services Administration, HRSA, have the states and other jurisdictions write an integrated HIV plan. This HIV integrated plan is an umbrella document that sets out local and statewide recommendations for HIV care, prevention, and treatment services, not limited to Ryan White programs, but also prevention-funded activities. During this process, the HIV working group is formed to develop the specific plan. Stakeholders, consumers, advocates, and community members should be able to share their experiences, barriers, and provide recommendations to the state and local planning groups as we create this planning document. And this is one of the many activities that we've been involved in to specifically solicit that information from these impacted groups. We want to hear from you, and we will continue to have listening sessions so we can address these concerns and find additional solutions. So again, on one side of the conversation, you have the statewide planning group. On the other side, you have the local district planning groups and other consortia. And we truly meet in the center to highlight collaboration, capitalize on synergy, and to truly capture the best ideas as we reduce the impact of HIV over the next 5 years. So if you've been involved, this is our fifth session. We started from a very high level conversation of individuals living with HIV and those impacted services. We had a conversation specifically at that intersection of HIV and stigma. We discussed housing and how it relates to HIV drivers. And tonight is a conversation geared towards prevention. So truly preventing HIV through the use of pre-exposure prophylaxis. So what is PrEP? Again, PrEP, it stands for pre-exposure prophylaxis. It is an HIV prevention method. PrEP is specifically for individuals who are not living with HIV. And, that is the key thing to keep in mind. PrEP is an option where we use HIV medicines to reduce individuals' risk when exposed to the virus. Some of the things to remember while we have this conversation is we are now in a place where we have different modalities of PrEP. So individuals can elect to use a daily option, so swallowing a pill, or folks can use a longer injectable option, so delivery through a shot mechanism. And again, I think one of the other important things that we must remember in this conversation is as we go on, especially over the next 5 years, we will definitely see additional modalities and additional options for individuals to select their best PrEP journey ahead. So despite having pre-exposure prophylaxis and despite having HIV treatment that are really effective, we continue to see an increased number of new diagnoses across key populations. This slide specifically highlights some of those advancements along the HIV care continuum for the last decade or so. And it really starts with 2010-2011 with the publishing of the HIV Prevention Trial Network study 052 that really showed that treatment as prevention works. That study provided treatment to people living with HIV, and ultimately those individuals who were virally suppressed or undetectable did not transmit HIV to their sexual partners. Amazing. And this study truly since 2011 have informed the conversation of prevention and care. We also see within this depiction is when Truvada was. Let me start. Okay, we also see when Truvada was specifically FDA approved for the use of HIV prevention for an HIV prevention method. We also see in 2012 that the FDA approved HIV home test kits specifically to provide your status at home. We've had some HIV test kits where you would mail the test kit in and folks would send you back your results. But since 2012, you've been able to see your status at home, and this is important. So again, we've had key changes along the last 10 years, but we still need more options to truly reduce HIV the way we need to see. I see a hand up. I can't see who the hand is, but please go ahead. Okay, we'll go back to the hand. So this is just a depiction from AIDS View. I just grabbed it off the AIDS View website, specifically highlighting additional insights that we see as PrEP is shared across the country. So we see in 2018, the South accounted for 31% of the national PrEP users. However, we still see the South with more than 51% of diagnoses. So again, the disparities are present, and this is leading the conversation on what else is needed to begin the reduction of HIV. This is a picture or just a depiction of PrEP coverage across the U.S. broken down by race and ethnicity. So we see while 23% of people eligible for PrEP were prescribed in 2019, coverage is not equal. So we see disparities across racial and ethnic groups, especially in comparison or especially in line with the ending the HIV epidemic target goals by 2030. So overall, in this red bar shows 23% of folks are taking PrEP who are eligible for it. And then when we break it down, racial and ethnic groups, those are the different color bars along the x-axis. And you see the lowest rates are among people of color, including Black and Hispanic. So again, we have to have a different conversation of getting impacted communities to PrEP, specifically around uptake, awareness, and utilizing the services. So we'll have Tito go over some slides specifically around PrEP and the District 4 public health response.
Well, before we get there, I want to introduce Dr. Malone to talk about PrEP with that from the state level.
Okay, how's everyone doing today? I want to just give a quick history of PrEP in Georgia. And PrEP began during two funding cycles. One is 12-1201 and the other is 18-1802. Before 12-1201 officially began, the CDC was gearing up to present PrEP as a community prevention tool. In doing this, they started creating deliverables around PrEP, and Georgia DPA's response was to develop a PrEP toolkit and the creation of several web-based educational sessions. Now, during 12-1201, DPH began doing more education, face-to-face and web-based. This was also inclusive of our toolkit, conferences, and our collaborations with the Kaiser Family Foundation, Georgia Greater Than AIDS, who created marketing tools and educational materials like Ask Docs, which was recorded sessions posted on the Georgia Greater Than AIDS page as well as YouTube to answer questions by the community and also by any of our health districts. Now, initially, it was difficult to get districts to develop PrEP clinics. And that was because of two things. One, there wasn't a guidance. And the second thing is that the dollars were restricted. Now, when I say restricted, I mean that grant funds could not be spent on the following: medical services, lab fees, nor medications. Our task was to address the lack of guidance by developing PrEP protocols, which were not available until 1802. However, we did have one PrEP clinic developed during our 12-1201 funding cycle. That was District 1-2, Dalton. The newly approved protocols, patient assistance programs, and the use of 340B rebates to develop and sustain PrEP clinic was one of the reasons that PrEP programs started to incline statewide. As of now, out of the 18 health districts, 16 have PrEP clinics, or at least a PrEP presence. And when I say PrEP presence, I mean this could vary in several different ways. Some districts open up a clinic 1 day per week. Some districts offer PrEP in its main health district offices. And lastly, some have integrated PrEP through its prevention services, meaning that you can go to any health department and receive PrEP services. 2 districts do not prescribe PrEP, and that is Waycross and Clayton. However, they do prescribe referrals. They do send out for referrals. At the moment, Fulton County does not use 340B rebates to sustain its PrEP clinic. And telehealth is something that we are trying to expand moving forward. We do have 2 districts that have been working with telehealth to enhance their program. That would be Fulton County as well as Macon. And Athens, Augusta, East Metro, and lastly, Cobb Douglas are very interested in pursuing telehealth to enhance their PrEP programs. In terms of positions or jobs associated with the PrEP programs, some would be nurse practitioner, health educator, PrEP navigator, PrEP ambassador, PrEP coordinator, clerk, linkage coordinator, and lastly, physician's assistant. Okay, Tito, take it away.
All right, Mr. Driffin, if you'll post.
Me 1 second.
Thank you. While he's pulling my little 6-slide presentation up, I'll just give you a brief introduction. So as I said at the beginning, I'm the HIV coordinator for District 4. We cover let's see, we'll get to the counties we cover. In just a second. So there we go. So that's our county coverage. We cover Carroll, Heard, Troup, Meriwether, Coweta, Fayette County, Henry County, Butts, Spalding, Pike, Lamar, and Upson. So that's our coverage area for our clinics. So next slide. Okay, so as Dr. Malone mentioned, as Mr. Daniel mentioned, the CDC helped develop and fund the studies for PrEP, and they also developed their PrEP clinical model, which, as Dr. Malone and those of us that work with public health know, we follow that clinical model. And I just wanted to put this up here first. And it starts with awareness, and that comes through promotion, engagement, education, or just to kind of sum it up, I like to call that outreach. Outreach activities. Then it comes to uptake, which involves the initial clinical evaluation, any assessments that need to be done when a person goes into a health department or an ID clinic, a brief history, usually referring to a sexual history of sorts, labs, counseling, and then the prescription of PrEP. And then at the very end of the model, usually it leads to adherence and retention. That is follow-up labs, patient assessment, prescribing refills, counseling, usually based around, encouraging the client to continue utilizing PrEP. But also, if it's a biological female, there could be pregnancy intent in there as well. Next slide. All right, so wanted to keep, kind of just give everyone like a brief overview of what we do here in the district. PrEP services have been folded into our health department general flows. Hard work was put into this by both the district and county health department staff in order to minimize the number of visits a patient must make for PrEP. Our nurses, when in the health departments, follow all Department of Public Health nursing protocols for PrEP, and all new nurses are trained in those PrEP protocols. So it starts off with client, usually enters the county health department requesting PrEP services. Any patient in any other program, like our STD programs, family plannings, and so on and so forth, can request at the same time as well, and vice versa. In other words, anybody can request PrEP services, whether they're already in the health department seeing for other services, or they're just newly coming in just for PrEP. All regular consents and intake paperwork is completed. The client is called back to meet with the RN. The RN completes the initial clinical evaluation and counseling. Required labs are completed. And for those of us that don't work with public health, those required labs are your HIV test, your serum creatinine, your hepatitis panel, hepatitis A, hepatitis B and C, chlamydia test, and a pregnancy test if the client is a biological female. Now, if client does not have insurance coverage, our HIV program actually will assist in covering cost of any labs that are not completed at our state DPH state lab. That is something new that we were informed of at the top of the year, which is wonderful. The RN then completes the Gilead advancing access paperwork with clients if they do not have insurance coverage. And what that's referring to is payment assistance. Then the client is scheduled to come back for lab results and prescription, and is done with appointment. They indicate on the form whether they would like to have their medication sent to a local pharmacy of their choice, mailed directly to them, which I'll tell you here in the district, a lot of our PrEP clients tend to prefer to have it mailed directly to them, or they can even have the medication sent to the health department themselves, and they can come to the health department and pick it up, and our nurses will, give it to them. that paperwork, that advancing access paperwork is sent to D4 communicable disease nurse coordinator, myself as the HIV coordinator. We meet with our medical director, who's Dr. Beverly Townsend, who signs off on it. Once she signs it, we send it back to the RN at that health department, who sends it off to Gilead. The RN will then complete the district HIV prevention PrEP time log, and it's a district level thing that we do, and we'll send to me, and we'll verify. And basically what this is, for those that are curious, this is just for that assistance that we talk about, that if a client doesn't have insurance, and those labs aren't sent off to a state lab, we can actually cover the cost of those labs. Next slide. All right, so the client then comes back for the next appointment and is provided with a prescription for PrEP. It is sent to Gilead and their insurance provider, if covered. Client will then pick either to have the medication mailed to them, sent to the local pharmacy, or sent to the health department, picked up, as we said earlier. They'll be scheduled to come in repeat labs per our nursing protocols, which is every 6 months. And that nurse will also evaluate PrEP need as a component of our HIV prevention every 12 months as well. Patient will then have a follow-up visit 1 month after PrEP initiation for adherence to counseling and any other additional reassessment. So basically, for the folks coming on tonight, I say all this to say that we folded our PrEP services into our regular flow. So anyone can come in and request PrEP referrals, and all of our nurses are trained to do it. We wanted to make this as easy as possible here at the district level. So that's kind of what we do at District 4. So, Dr. Malone, anything else?
No, that was great.
All right, Mr. Driffin.
Excellent. Thank you, Tito. So again, very similar to our other conversations, we are just going to jump into 3 high-level questions, okay? That first one, let me share the questions. Sorry about that. Just a second. And I'll leave it in this mode. Are you guys able to see this, the community conversation slide?
Yes.
Okay, excellent. So 3 high-level questions, really. The first one, what are some activities to increase PrEP uptake across Georgia? The second, what is working well? What can be improved? And the third, what services and additional options that we can implement to complement PrEP across our state? Feel free to raise your hand, and we will go from there with our discussion.
Well, I'll go ahead and start a suggestion off. As you see, I said in the chat, and I talked about it in a little bit, I think that more outreach is required. Outreach to the communities that we're trying to reach out to.
Thank you, Tito. I see Phyllis' hand is raised. Phyllis, go ahead and unmute, friend.
Thank you. So some of the activities we can do is, first of all, address barriers to care. One main one being transportation.
Phyllis, tell us where you are calling in from.
Oh, sorry about that. For those who don't know me, I'm Phyllis Mwaura, calling in from Gwinnett Health Department. I'm the HIV Prevention Program Manager.
Excellent. Thank you, Phyllis. So transportation continues to be a barrier. I see within the chat, is it possible to increase the number of same-day PrEP centers in Atlanta and across Georgia? I'm going to add across Georgia. I'm a new volunteer for A Vision for Hope. Thank you, Will. So I think that's a great point to be made, increase same-day PrEP options across our state. what else comes to mind? Anyone? And again, we don't have to do the questions in order. Feel free to, begin where you would like to begin. Jeff, please go ahead.
Yeah, thanks, Daniel. So it actually, I have a bit of a question, and I'm wondering if, I know we've got a racial demographic breakdown, but if at some point we could see a breakdown by age as well as race, and then frankly, I would love to go even further and see it either by health district or region or something there, because I think that to really get at some of these questions, it might be helpful if we had a bit more analysis of the data. So that, Tito, I couldn't agree with you more. I mean, there needs to be more outreach, but does outreach in Atlanta look the same as outreach in Savannah or Albany or Augusta? And so I think if we had some additional data, that might help us. And so then what I think might help with some of the activities is not just outreach to people at risk, but outreach to other institutions that could be gatekeepers. So making sure that college health services know about PrEP, and ideally that they would be set up to provide PrEP, but at the very least that they can work in partnership with the local health departments, the local health districts to do referrals. School health programs, and these are in high schools. Similar thing there. At Georgia Equality, one of the things that we had done a couple of years ago, we worked with State Representative Park Cannon, and she went to Attorney General Chris Carr to ask if the current laws that allow youth to access STD prevention or STI preventive services without a guardian permission, if PrEP followed into those guidelines. And the Attorney General said yes. So I think that that's an informational piece, again, to empower young people. This is kind of a bit of where I'm going with all of this, is I think that some of it is doing better outreach by age group as well, so that younger people are aware of PrEP access and their ability to take more control of this into their own hands. And then the last thing, and I certainly don't want to derail the conversation, so maybe I'll put my email address into the chat and we could set up a separate session. But one of the things that Georgia Equality has been considering doing is looking at changing or enhancing some of the pharmacy laws here in Georgia so that private pharmacists can dispense PrEP. And one of the questions I have is this something that works to support what's going on in public health, and how do we make that happen? So, for instance, pharmacists at Walmarts around the state, and how do we train those pharmacists so that they can be a bit proactive as a provider site? And then what should that look like? There's several models around the country of what these policies and legislation looks like. So I just wanted to toss that out there. And so if anyone is interested in that conversation, again, I don't want to derail tonight, but I think that I would really be interested in getting a group together to start thinking about that issue. Thank you, Daniel.
No, thank you, Jeff. And I definitely think that last point that you made is valuable. I think also, highlighting and empowering youth to select the best health choice is oftentimes not brought up in these types of sessions. So I definitely think that would be really, really impactful. I see our friend Leisha hand is raised. Leisha, please.
Hi, good evening, everyone. Just a couple of things. I actually wanted to start with Jeff's last comment, Jeff, I think that is an amazing opportunity to look at pharmacists being able to prescribe PrEP. I'm actually working with the Utah State Department of Health as they're rolling out their PrEP pharmacy initiative. So I'd love to talk more with you about that. But I think overall about our own PrEP program, there are a couple of things that we need to really focus on. And one of those things is that we've got several different groups working on PrEP for Georgia. And I think that being able to come together and to address some of the same issues that everyone is probably seeing would be more beneficial for the state. We've got our EHE CAB that also has a PrEP advisory committee as well. And one of the things that we've been talking about through that committee is what would a possible PrEP drug assistance program look like. So we, very similar to the ADAP model, is we're hearing from some of the organizations, both large and small organizations, the medications, covering the cost for the medication isn't the issue, it's the labs and the co-pays. And so what might the state PrEP drug assistance program look like? We can't ignore that when we look at media and marketing for PrEP, it is not the same across populations and across regions. And so we have to address how are we marketing PrEP for Georgia, as well as our locations beyond just HIV serving organizations. The Atlanta Black Women Leaders on PrEP did a survey last year to identify locations where women could access PrEP and gynecological services under one roof, and only identified 4 locations throughout Metro. So if that's an issue in Metro, I can only imagine how limiting that may be for the rest of the state. And so I think it's important that we are addressing PrEP across all populations. Last week, we just had the PrEP in Black America Summit here in Atlanta, and looking at the deficit of PrEP uptake among Black populations, including the state of Georgia, and what some of those issues are. And the last thing that I will say is highlighting some of the structural issues as well. Looking at doctors who might not even have conversations with people of color about PrEP as they are coming into some of our Georgia facilities, acknowledging that everyone who is utilizing PrEP is not going through one of our health departments or health districts. So how are we educating and expanding PrEP utilization outside of our HIV structure as well?
Thank you, Leisha. Really, really appreciate it. I see within the chat is coming alive and it's beautiful. Some things include ensuring marketing and awareness go specifically for women and people who are living with disabilities. I see address language barriers when it comes to providing information about PrEP, especially to patients. I also see PrEP ambassadors. Phyllis, you want to say a little bit about PrEP ambassadors?
Sure. For example, someone mentioned about getting PrEP access in colleges, in populations, for example, women. We have women in college students that have used PrEP over the years, and we can make use of these people that are already known by their populations to kind of increase marketing and reach out to those populations that we're not able to reach.
Got it. Thank you, friend. Anything else that comes to mind that we haven't highlighted just yet? Have we heard any, programs in other jurisdictions that, may provide some support here in our area? Okay, all right. Now I'm 4 hours behind you guys, so I can understand why I have so much energy right now. But what comes to mind? I did see a question for Tito. It says District 4, how many days does it take for new PrEP patients to get meds through your program? Do you have any anecdotal information on that, Tito?
I was actually typing an answer to that as we spoke, but I'll go ahead and say it. What we're seeing is that it's 2 to 4 days, somewhere between 2 to 4 days after the referral sent off, depending on what the client chooses as their vector. When I say vector, for those that are wondering, I'm talking about whether I'm using vector to describe whether they want the medication to be mailed directly to them, whether they want it mailed to a pharmacy of their choosing, or if they want to get it sent to the health department to come pick up.
Thanks. And maybe, Tito, you could talk to just high-level information around retention, because I think one of the most important conversations that we fail to have is, yes, we can get people to PrEP, but are we ensuring people staying on PrEP to remain negative?
Well, I can tell you what we're seeing in District 4 is it really depends on the person and whether or not how much they want it. We've had folks who come in and set to our health departments. To give an example, to our Troup County Health Department in LaGrange, we had some clients, a client come in last year, the year before when we first started, and identify they want PrEP. They did all the labs, they did everything, but then health department staff can never get back in touch with them. So it really depends on the person on how much they want to get, to be on PrEP. But our health department staff, when it comes to that, they're very good about, reaching out to them to remind people of appointments, calling to remind our call centers do a lot of that as well. It just, once again, it's just based on how much a person wants to be on PrEP that we're noticing.
Got it. Thank you, Tito. And this is for anyone that's listening. So I know we're mindful that oftentimes individuals start PrEP based on the relationship that they may be currently in. And if that relationship status change, oftentimes PrEP use can stop, reduce, or increase. So I think, we also have to be mindful of how we message PrEP, and regardless of an individual's risk or vulnerability to HIV, but truly having a higher level and more collaborative conversation that this is a prevention option long term. So if anyone has additional insight, feel free to share that with with the populations that you may work with. I see Damon is saying yes in the chat. What does that yes mean, friend?
I just think what you said was profound, and I saw Will put something in the chat as well around just empowering people in a different way. So I think that empowerment is definitely something that we need. Being a PrEP user, I think when I switched from looking at it as a punishment for my lifestyle to a liberating thing, it really helped me. It motivated me to be on PrEP and stay on PrEP.
Got it, friend. I really, really appreciate that. Will, if you're in a position to unmute, we would love to hear any feedback that you can provide. I see we have some chat going back and forth around staff being willing to discuss sexual health in rural areas is important. I would say the same staff being willing to have that conversation in a metro in a metro context as well. You know, we
Any
continue to
place.
we continue to see it being difficult to take sexual risk, sexual health assessment across the platform. So I think that's really important to lift up as well.
Daniel, I'm in the airport right now.
Oh, friend, I totally understand. you be safe, okay? So what are some of those complementary services that could be paired with PrEP as we think about rollout over the next 5 years? Jeff, please go ahead.
Yeah, so hopefully this wouldn't be a 5-year plan, but I'm just wondering, are health departments including information on PrEP with the monkeypox events, the monkeypox event vaccination events that are going on? So I was out at an event recently in DeKalb County, and they walked through asking people if they wanted to have an HIV test, which I thought was a great opportunity as people were sitting in the observation area just waiting for their time. But the conversation tonight, I also think it would be just a great time or opportunity with some of the packets they were giving out with home HIV tests, home COVID tests, to actually include a flyer on how to access PrEP at your local health department.
Daniel, I can go ahead and answer some of that, at least from my health district perspective. We do. A lot of our monkeypox clinics right now have been in health departments themselves. We have evening hours for them when we do them, and we talk about everything. They're offered all services, including PrEP when they come in.
Yeah, I know one of the national approaches that have been underway is, a viral response. So pairing monkeypox with HIV, and we'll have flu starting next week probably. So it makes sense to also include information about influenza and even COVID boosters. Because again, like these are the same communities that are disproportionately impacted by all of the epidemics when we think about it. I see Peter hand is up. Peter, please.
Hey folks, thank you so much for the presentation this evening. Regarding the wraparound services with monkeypox, Pete Clark, I'm the EHE Program Manager for Gwinnett, Lincoln and Rockdale. We've just recently concluded our monkeypox mass vaccinations. We vaccinated over 7,000 people. At those events, we actually did points of care HIV tests for over 500 people. 700 people, and provided over 500 home tests. We also had lots of information about linking people to HIV linkage services and also access to PrEP. So yes, through the monkeypox, we were able to provide complete holistic wraparound HIV services.
That's excellent. And thank you for highlighting those ongoing services that you guys have provided across the Gwinnett, Newton, and Rockdale County, Peter. Really, really appreciate it. I see some chat. Tammy, regarding relationship, jumped away. Okay. Regarding relationship status change, we as providers, coordinators, etc., must ensure that we participate in capacity building. Yes, motivational interviewing, workshops, or just brainstorming how to come up with strategic ways to talk about events to just stay on PrEP, even outside of a relationship. Really, really important. Thank you, Tammy. Really appreciate that. I see ongoing conversation on giving information out about condom subscriptions. That is excellent. And consistent education is important. Yes. All those things are really, really crucial when we think about a holistic PrEP plan for individuals. Kevin, I see some chat interactions. You want to unmute and say a little more?
Hi, yeah. So when thinking about marketing, just like I wrote in the chat, how Coke and McDonald's markets their product to make the consumers say, oh, I want that. I think a lot of the marketing that I've seen around PrEP has been a little passive, more so than reaching that part of the consumer that says, oh, I want that kind of marketing. That's it.
Got it. Thank you, friend. Appreciate it.
Daniel, real quick, I'd also like to highlight, computer just did something weird. Miss Xenia really in the chat mentioned that we also gave out information about our condom subscription and gave out condoms. And I wanted to also highlight that with PrEP, condom usage and education on condoms is so important. And I think that that is something that could complement PrEP as well as condom usage itself. Because as we know, condoms will protect you from not just HIV, but other STDs. You know, PrEP only protects you from HIV. It doesn't actually protect you from other other STDs, or if the client's a biological female, you know, there's pregnancy that could become a concern as well. So I think that condoms need to be an important part of this conversation as well.
Thank you for that. Really, really appreciate it. Anything else from anyone? When we think about, you know, bringing PrEP to folks who need it the most, you know, could we imagine a PrEP clinic at, you know, a MARTA stop or at a MARTA station? You know, can we imagine PrEP clinics, you know, in key communities, especially, you know, if we place PrEP clinics across communities where we see a higher detectable amounts of viral loads, you know, just truly bring in services where people who need services the most are. I see PrEP plus condoms equals fun, healthy sex. Thank you for that. Michael, I think you should just unmute and say what you just wrote in the chat. It's going back and forth. Let's try it one more time. Okay, I'll read some of it, Michael. There he is. Go ahead, Michael. Yes, sir.
Okay. Yeah. You know, I've been around for a few years, and I'm always thinking back to some of the early days when we first started working in the AIDS epidemic and how scary everything was, especially when it came to taking pills and using medication for treatment. And I just wonder if some of those same things may be part of the problem we see with people accessing PrEP today. I know we're all very familiar with the structural barriers that prevent people from accessing PrEP, but I think there's probably also maybe a social and emotional aspect of it too that we haven't fully wrapped our hands around and addressed. So I just thought it might be interesting if we could, and I don't know, maybe some of the groups that are looking at PrEP are already addressing this, but just to get some more insight to maybe what some of those reasons are that a person who has access, who there are no barriers, they may have insurance, or they understand how they can get connected to a PrEP program, why they're not taking that step, and then seeing what we can do to address that. You know, there were so many things that we did back in the early days of treating HIV to help people once we had them in care to start taking medication. And a lot of that was providing support and answering questions in a very individual, tailored way. So I think it might be worth it to try to find some of those people. Tito, you said it depended on how badly they wanted it. And I think maybe some people really want it badly, but they're still not accessing it just because they don't feel confident in their ability to be able to take the medication. How secretive can I be while I'm doing this? Who's going to know about it? And how do I talk to people about the way I feel and why I'm taking this medication? What does it mean to my family? What does it mean to my partner or partners? And how do I have those kinds of conversations? So I think it gets kind of deep when you look at it from the perspective of one of those people that may appear not to be so interested or not to be so motivated. Maybe they are, but it's still just beyond their reach. At least they feel like it's beyond their reach. That's basically what I was saying in that long chat that I put in there.
Got it, friend. Thank you so very much. I see Brian hand is up. Brian, you want to go ahead?
Yeah, great. Thank you, Daniel. I think my thought was similar in certain ways with Mr. Siebold's mentioned. One of the things that seems to be a big barrier to PrEP is that people don't clearly see their potential risk for seroconversions. So I think it might be interesting to see if G-PACC can partner maybe with one of our research institutions to perhaps find a subset of folks who are recently found out that they are living with HIV, maybe in the last 2 or 3 years, et cetera, and do a kind of simple survey to say, did you know about PrEP? And then a few subsequent questions like, what was did you consider it? What were some of your barriers? Did you think you need it? Why did you? Because I think we need to find out more about why people do sort of underestimate that potential. And the people who probably did a great deal of self-examination are the people who recently found out that they were living with HIV. And then they may also, because they probably did know about PrEP if they were recently, they may be asking themselves, why didn't I? And that may provide information for people to work with. Just a thought.
No, I think that's a great point. I work along many community aspects of the HIV care continuum. And one of the newer activities I'm working on is the HIV Prevention Trial Network 096. And it's an integrated strategy randomized trial, specifically randomizing communities at the community level. So we're randomizing entire cities, in states. When we think about what are those integrated services that can be provided. I dropped the website in for more information. But one of the things that, we use to make a comparison of like city to city, jurisdiction to jurisdiction was the prevalence rate in these communities. I think one of the things that we do not highlight within any of our jurisdictions is how high HIV prevalence is among groups at risk for HIV. So if you're in a zip code or even a sexual network where 45 to 54% of your sexual network is already living with HIV. I think when we add the conversation of individuals say they didn't see what they were doing as a risky activity, I think that makes sense when, prevalence is so high already. So I definitely think these are these are the higher conversations that we have not always had in creating our treatment and prevention options for those at greatest vulnerabilities to HIV. But I definitely think those are some things that we must remember moving forward. So see, that's a great point at Kevin. Unfortunately, there's a perception that PrEP is only for gay men. We need to alter messaging, including heterosexual individuals and persons with disabilities. Yes, yes, yes. And just additional ditto with high prevalence in areas and sexual networks. Thank you for that. Anything else? We're nearing, our time to go home time. But if anyone have any, I'm not going to mess up that. I'm not going to mess up that first name. But your last name is Francis. Would you like to unmute and tell us a little bit more about what you added to the chat box?
It's Tia. Hello, everyone.
Hey, Tia. Thank you.
Hey, hello. What I was just stating is possibly getting a buy-in from the community instead of us guessing what people want, find out from the community that we see that there's a greater need for, and ask them what it is that they want. Make it fun, as it's been stated by Tito, like an outreach type of thing, more of a fun PrEP learning situation, to not make it so scary or something that we shouldn't go near that topic. So make it something more engaging, invite them in and then include them in the process for those who's willing to participate and bring them to the table and allow them to be the ones to draw the individuals in their community that they know will benefit from it as well.
Absolutely. You will never not have my support on letting community decide what's best for them. So thank you for that, friend. Any last minute ones?
Real quick, Mr. Daniel, I want to also point out too, because Tia mentioned people don't like to take vitamins consistently, and that is another barrier to, a lot of people don't like to take pills, and right now PrEP is the pill itself is a once a day thing, but there is the injectable that was just approved by the FDA, cabotegravir, and it starts out with 2 injections, one month, and the next month you get an injection. And then after that, it's every 2 months you get an injection, and that's PrEP. But it's still in the early stages as that. It's been approved by the FDA, but they're still working on payment assistance plans and everything else. But it's an injectable, so it's an option for those that don't like to take pill medication.
Yes, absolutely. And even being mindful of other modalities which may not be FDA approved, specifically like the 2-on-1 option with oral, PrEP. But I definitely think, these are additional conversations that we must, inform community and have community select the best way forward for them. So thank you for that. So before I let you all go, allow me to say thank you. Over the last month or so, I don't know what happened. Okay. Over the last month or so, we've had the great opportunity to have these listening sessions on very important topics, especially as we think about the drivers of our epidemic. Keeping in mind that oftentimes these drivers that we continue to see are closely connected, through structural and social determinants of health. So like housing, insurance access, the role of stigma, the role of, employment, transportation, those types of things truly continue to negatively impact the populations that we are creating solutions for. We would like to say thank you on the behalf of G-PACC and the Planning Council in taking time out over the last Tuesdays to participate in these sessions. We've had more than 150 participants from the start of the series to tonight. And it's not too late to submit suggestions for our integrated care plan. You can easily respond to any of the emails where you received your registration link from, or just contact one of us. We hide in public. From myself, Tito, Miss Sandra, Vivian, anyone with the DPH email address. You know, we truly are here to inform the best strategy forward. I would also say in closing, we love to see new faces. So please, please, please consider joining one of the Ryan White Planning Council meetings in the future, or even one of the G-PACC's, the
Quarterly
G-PACC's quarterly meetings. For more information, I promise you, I feel like it's 8 o'clock already. But for more information, feel free to email us, contact us, chat us. We are here. Again, thank you, thank you, thank you. And this is just some of the emails that you could be contacted on. Before I say goodbye, would any of the organizers like to say anything else?
I'll say this, that G-PACC would like to really thank everyone for participating in this, because the work we do is so important. And, you know, we want to make sure that we provide the best integrated plan for the next cycle that we can, the state of Georgia does. So we at G-PACC would like to thank everyone for participating in this.
Thank you so very much. Anyone else?
Daniel, on behalf of the Planning Council, I just like to thank everyone that's participated over these various series that we've had. I think we have great takeaways. I think we brought some very powerful, positive, and change warranted information to the discussion. I really see a lot of value in even continuing these discussions, maybe quarterly, as a way in which to check in with the public. I want to especially highlight the fact that we were able to work with G-PACC on this initiative. This is an integrated process, and I think it speaks volumes to our leadership, you being one of them, Daniel. You've done an amazing job, and next Tuesday, I'm going to be looking forward to tuning into your podcast. Because I think you have a podcast in you. But thank you. And I will say this as well, and then I'm done. But today I was getting several emails from different individuals. Leisha, Tia, it's so good to see you on here tonight. I am so glad that we were able to even capture another audience, another demographic on tonight. And that just speaks to the fact that we were very diverse in our subject matter, and it says that we've done something right. So if there are other areas that you think that we need to include, other information that you think that we need to consider, please email any of us and we will make sure that the information is put forth.
Yes, yes, yes. And that even goes for if there's additional listening sessions among populations that have not been included in any of the previous series. We are more than happy to set something up and truly bring this message to that group. So Tia, if you have anything in mind, do not hesitate to get in touch with Alicia, Miss Sandra. They'll send it to me and we will be there, okay?
Daniel, I would like to see, and I don't know if it's doable, but Maria, I really would like for us to look at possibly having a listening session that is specifically geared towards Latino individuals. I think that would be very powerful, especially in light of the fact that we recognize this as a demographic needing special attention. But if there are any individuals that are on this call that would be interested in working with Daniel and Vivian on putting that together, I think that would be a very positive move forward.
Sure.
Absolutely, absolutely.
Yeah, sorry, I have to comment. Sandra, I think that's a great idea. And I would encourage you, if you get that together, reach out to Jerry Gonzalez at the Georgia Association of Latino Elected Officials, GALEO, because I'm good friends with Jerry, and I would be very open to helping with this. Again, I think Leisha was the one who highlighted this. I think sometimes it can be very helpful if we get out of the HIV silo to reach people. And I think this might be a great conversation to do that. And GALEO may be a great organization to be able to help with that. The Gigi put, I forget her last name right now, but the Latino Action Fund can also maybe help with that. So again, if I can help make some of those connections, please feel free to reach out to me.
Thank you.
Thank you so very much. You all be well, and we will talk very, very soon. Again, thank you all for your time and participation in this series. See you guys soon.
Thank you, everyone. Good night. It was wonderful.
Thank you.
Everyone.
Good night.
Thank you.